Hi, my name is Dr. Andrew Bindman, and I'm a professor of medicine, health policy, epidemiology, and biostatistics at the University of California, San Francisco. I'm pleased to have an opportunity to address you all today about federal health reform and its impact on radiology practice. The Affordable Care Act, or federal health reform, became law in March of 2010. The ACA will have a big impact on increasing the number of people who are insured. It is estimated that there will be 27 million people who are currently uninsured who will gain coverage. And it will also stimulate significant changes in the organization of physicians, primarily through new payment models. I'm going to talk to you first about what the Affordable Care Act will do regarding expanding insurance coverage to the uninsured. The main date in which the biggest changes will happen is January of 2014. But prior to January of 2014, there are already some changes underway to expand coverage to the uninsured. For example, in most states, there are now high-risk pools for those who have been denied coverage, and it allows a relatively small number of people, but an important group of people who have been denied coverage to be able to gain coverage through state health insurance high-risk pools. These pools will not continue beyond 2014 when the more significant parts of health reform are implemented. The other thing that has happened already is that health insurance coverage has been expanded to children who are up to now age 26 who are dependents on their parents' health insurance coverage. This has been a significant change already, where over 3 million young adults have gained coverage by being able to have to remain on their parents' health insurance plans. Also, a change that has already occurred is that there is no longer the possibility of health insurance plans excluding children with pre-existing conditions from being able to gain health insurance coverage. This is very significant for families who have children who experience chronic illnesses and other serious health conditions that have prevented them from getting health insurance coverage. As I mentioned, the most significant change in coverage begins in January of 2014, where there'll be three things that happen together to expand coverage. First, individuals will be required or mandated to have health insurance coverage. Secondly, that one of the main ways that this will happen is through expanding the Medicaid program, the largest public insurance program for low-income people in the United States. More people will gain coverage through Medicaid. And third, it will improve access to private insurance coverage, particularly for individuals and those working in small businesses who have not been able to get health insurance coverage through their workplace. As I mentioned, it's been estimated that there will be approximately 27 million people who are currently uninsured who will gain coverage. This has been a little bit of a change from when the law was first passed, and this has to do with the Supreme Court ruling related to the constitutionality of the Affordable Care Act. Prior to the Supreme Court ruling, it was estimated that 16 million people would gain coverage through Medicaid, 16 million people would gain coverage through private insurance, and that approximately 95% of U.S. citizens would have coverage. After the Supreme Court ruling, in which there was flexibility given to states about whether or not to expand Medicaid coverage, it's now been estimated that 12 million individuals will gain coverage through Medicaid, 15 million through private insurance, and approximately 92% of U.S. citizens will have gained coverage. Of course, these numbers could be larger if states which currently say that they are not going to expand Medicaid coverage do in fact do so. This cartoon represents how individuals will gain health insurance coverage under the Affordable Care Act. This will be slightly different for children versus adults, but will comprise the same mixture of using the Medicaid program and credits from the federal government to help individuals buy insurance through an exchange. In the case of adults, those who are below 138% of the federal poverty level will be covered through the Medicaid program, and those above that level will gain insurance coverage through the exchange, with help from the federal government with financial credits up to 400% of the federal poverty level. This will be done on a sliding scale basis. It will be similar for children with one difference, and that is below 138% of the federal poverty level, It will be a mixture of the Medicaid program and the Children's Health Insurance Program, depending on how states decide to mix those two programs together. And then above those levels, again with some differences a little bit in states, but in general, above those levels, children will gain access to private insurance through the exchange with credits from the federal government. One thing that's important to understand is, depending on your state, an individual will be eligible for either the exchange or the Medicaid program. It won't be a choice for individuals which they want to go into. Now, many people understand that the Medicaid program is the largest insurance program for the poor. So what's different about the Affordable Care Act, and how is the expansion of insurance happening through that program? Well, currently, eligibility for the Medicaid program is based on categorical need and being low income. What I mean by that is that you have to either be a low-income child or a parent of a low-income child, a low-income pregnant woman, a low-income individual who qualifies on the basis of a disability, and those groups are the only ones that are currently covered by the Medicaid program. What is going to happen is that low-income adults who currently do not have children, who are currently excluded from the Medicaid program, will, beginning in January of 2014, to be able to gain Medicaid coverage. So if you are a low-income adult, less than age 65, and your income is less than 138% of the federal poverty level, which in current terms is about $15,000 for a single person, or about $30,000, $843 for a family of four, you will be eligible for the Medicaid program. The other part of the Affordable Care Act in terms of expanding insurance coverage is through what I mentioned are something called insurance exchanges. And these are a sort of farmer's market that will bring together health insurers to interact and to sell insurance coverage to individuals and those in small businesses who typically have difficulty gaining access to insurance coverage through work, as many individuals do who work for larger employers. What these insurance exchanges will do is, first of all, a very important thing in terms of defining what is meant by insurance coverage. And this will be defined at 4 different tiers: bronze, silver, gold, and platinum. And these correspond to the different expected amount of health costs that an individual can anticipate paying out of pocket in conjunction with their health insurance plan. So, for example, those who purchase a bronze level plan can anticipate that 60% of their costs will be covered by that sort of health insurance plan. Those in silver, 70%, those in gold, 80%, and those in platinum, 90%. What this does is standardize what is meant by health insurance, and therefore helps consumers to know what they're purchasing. And that then sets up the opportunity for a competition based on price that isn't changing the nature of the benefits that is covered by these plans, but is changing other components like the co-payments and deductibles and how those are structured. As I mentioned also, low-income individuals up to 400% of the federal poverty level will get subsidies from the federal government to help them to purchase health insurance through the exchange. So those between 138 and 400% of the federal poverty level will be eligible on a sliding scale basis for those subsidies, which will average about $5,000 to $6,000 per family. The other thing that is changed under the Affordable Care Act is that there will be no pre-existing condition exclusions. As I mentioned, this has already kicked in for children, but it will also apply to adults beginning in January of 2014. So a health insurance plan cannot exclude adults or children from being able to purchase insurance come January 2014. What this also means is that individuals will have guaranteed issue from an exchange. That is, if an individual says, "I'd like to purchase a particular plan," the plan does not have the opportunity to say, "We do not want to have you be able to buy insurance from us." It's guaranteed that the plan will be issued if a consumer chooses that through the exchange. Finally, the exchange has a mechanism of controlling costs, whereby currently individuals can face very high rates if they have prior conditions compared to those who are younger and healthier. What is happening under the Affordable Care Act is there's a much narrower difference in the amount that can be charged, and it cannot be done on the basis of health conditions. There is an ability to charge different rates a little bit based on age, but it's a much narrower difference than currently exists in the health insurance market. Now, one question one can ask is how much of the new funding toward health insurance will in fact reach physicians? It has been estimated by the Congressional Budget Office, the CBO, that $168 billion will be spent for coverage expansion in 2016, one of the early years, so just 2 years into health insurance expansion. On average, currently, about 20% of all healthcare spending does go to physicians. So therefore, if one does a simple back-of-the-envelope estimate, physicians can expect that in the ballpark of about $30 billion in new funding in 2016 will be directed toward physicians. This corresponds, in relative to the current amount of money that Medicare spends on the current amount of money that is directed to physicians for health insurance coverage, that 5 to 6% increase over what is currently directed toward physicians. So this will be a significant increase in the amount of money directed toward physicians because of increased coverage expansion. Now, the other major change that has gone on with the Affordable Care Act is bringing about anticipated changes in the payment model for the Medicare program. What is anticipated is that there will be a decrease in the use of pure fee-for-service reimbursement through the Medicare program. There will be an enhanced use of performance-based incentives based on quality to try to reinforce quality through the payment mechanism. Third, the use of bundled payments, that is to pay for episodes of care in a one lump sum sort of way to try to control costs that way. And then also to change the organization of physicians through the payment model. And the most dramatic example of this are accountable care organizations, or ACOs. The performance-based payment changes are already beginning to happen through the Medicare program. And as I mentioned, the idea here is to tie a portion of Medicare payment to quality of care. One way that this is happening in the hospital setting is that hospital financial penalties are now in place for things like high rates of hospital readmissions and for hospital-acquired conditions, patients who get an infection as a result of their hospitalization, or other conditions which are signs of lower quality of care. For physicians, there's now been the development of something called Pqrs, the Physician Quality Reporting System. This is a voluntary system in which there is a 1.5% bonus through the Medicare program tied to physicians being willing to report and ultimately related to the quality of care that is reported by them. At this point, there is only a bonus available, but it is anticipated that with time, the Medicare program will incorporate penalties for those who do not participate in the program. Of note and related to this conference in general is that a portion of that 1.5% bonus will be tied, in the case of radiologists, to maintenance of certification. And this can be met by reporting radiation dosing, which is an important measure of quality that the Medicare program is recognizing. Well, the accountable care organizations is one of the most significant delivery system changes that is anticipated under the Affordable Care Act. Accountable care organizations, or ACOs, are provider networks, hospitals and doctors, that take responsibility for a defined population of at least 5,000 Medicare patients. These organizations will be accountable for the costs as well as the quality and overall care for that population. The opportunity for the providers that take on this responsibility is that they have an opportunity for risk sharing, the financial risk sharing with the Medicare program. It's also anticipated that over time there'll be the development of reliable and progressively more sophisticated performance measures to support improvement and provide confidence that the savings are achieved through improvements in care rather than withholding the delivery of appropriate care from patients. Now, when some people hear about accountable care organizations, they think, gee, that sounds a lot like managed care. But in fact, there are a couple of important differences that you should be aware of. First of all, payment in an ACO is tied to fee-for-service rather than capitation, which is more typical in managed care organizations. The fee-for-service mechanism in the accountable care organizations is how they're designed now. It's certainly possible that it could change to more of a capitation model over time, but at this point it is driven off of a fee-for-service system. Secondly, the payment in an ACO is risk-adjusted based on the historical costs for the patient population that the ACO is responsible for. This is different than what happened in many managed care organizations, where there was a per capita cost that was rarely adjusted for the health status of the individuals who were assigned to that health plan. And finally, payments in an ACO will also be very much dependent on the quality of care that is delivered by that organization. Again, many managed care organizations do not tie their payment to quality of care measures, where ACOs will require this. Now, Medicare ACO models will come in two different varieties. The most commonly used at this point is what's called the Medicare Shared Savings Program, or MSSP, and there are currently 220 such ACOs. A second vehicle is called a Pioneer ACO, and there are 32 ACOs of that variety. And I'll tell you a little bit about each of these two different programs through the Medicare program. The Medicare Shared Savings Program is a program that requires a 3-year minimum contract between the ACO and CMS, which oversees the Medicare program. It does require a minimum of 5,000 Medicare beneficiaries be covered by that ACO, and the attribution of which beneficiaries an ACO is responsible for is based on where the individuals receive the majority of their primary care. In the case of patients who do not receive care through primary care, there's also a secondary mechanism through which where an individual gets their specialty care can also be used to determine assignment to an ACO. But for most patients, it will be done on the basis of where they receive the majority of their primary care. For each ACO, there's a specific baseline related to the average annual cost based on the previous 3 years of costs for those individuals assigned to that ACO. The ACO projected cost is then, what's anticipated to be the cost is the baseline amount based on the prior 3 years, then adjusted for the national growth in Part A and Part B of the Medicare program over the period going forward. So in essence, the patient population's health status is accounted for by the historical cost for these patients, but going forward, their growth in cost is going to be determined based on national growth rates in Part A and Part B expenditures. So how do the shared savings and losses actually work? Well, there'll be an annual comparison by CMS of the actual per capita spending to the projected cost for the population assigned to that ACO. If the actual amount of spending for the population in the ACO is less than what was projected to be, then the ACO gets to share savings. However, there's one other aspect, which is that it gets to shared savings after exceeding a projected minimum savings rate, and that the ACO demonstrates that its quality of care meets or exceeds quality targets for its organization. In calculating the actual costs, the ACO is responsible not for paying the costs, but for the accounting related to the patient population, regardless of whether the care occurred in the ACO. So, in the Medicare program, beneficiaries retain freedom of choice to see any provider they like. However, the ACO is going to be responsible for any patient that receives the majority of its primary care from it. If patients receive services outside of that ACO, those are included in the balance sheet of determining whether or not the ACO was able to keep its costs below the projected targeted amounts. So it's very important from the point of view of the ACO to try to make it attractive for the patients to seek care through the ACO, and then once having the patients in that setting to to manage them in a very cost-efficient way. The Medical Shared Savings Program actually has two tracks that also recognize differences in terms of providers' willingness to take on risk for the patient population. In track 1, there is no downside risk in the first 3-year contract. That is, if the ACO ends up exceeding projected costs, the ACO is not responsible for paying that difference back to the Medicare program. It is still paid on its fee-for-service mechanism, but it will not benefit from any of the shared savings if it does not generate those, and it won't have any downside risk if it's a Track 1 program. On the other hand, in Track 2 programs, these are ACOs that have agreed to take on an immediate downside risk of up to 60% of the costs. And so that in those cases, if the target is not reached, there is a risk for those ACOs that they may have to pay money back to Medicare if they do not come in below the projected target amounts for their Medicare beneficiaries. I mentioned also that an ACO will not benefit from shared savings until they exceed some minimum savings rate. In the case of the Track 1 organizations, that rate will vary a little bit depending on the size of the number of beneficiaries that are taken care of by that ACO. In essence, if you take care of a smaller number of Medicare beneficiaries, then the amount you have to exceed is somewhat higher. We're still talking about single digits, but you do have to exceed a higher amount just because there's greater risk of error or random chance that you will exceed some savings, and so that the amount you have to exceed is somewhat higher when you're taking care of fewer individuals. In the case of Track 2 ACOs, the minimum savings rate is set at 2%. That is, once you have savings that are beyond 2% of the projected cost, then you can start to share in the savings with the Medicare program. In the case of the Track 1 program, you can have up to a 50% shared savings, up to 10% of the total costs, whereas in the Track 2 programs, the maximum shared savings is actually up to 60%, up to 15% of the total cost. So there's a higher amount that you can gain if you are willing to be a Track 2 program, but there is that downside risk. Track 1 programs are only able to do this with Medicare with their first contract, that is with the first 3-year period, and then subsequently would have to transition over to a Track 2 type program with their subsequent contracts. If you're a Track 2 program coming in right away, you always have to be a Track 2 type program going forward. Now, in addition to meeting the financial targets, ACOs will also have to meet certain quality measures. And there are currently 33 measures that an ACO will have to demonstrate their performance and exceed a threshold set of expectations in these areas in order to benefit from the potential shared savings. Of these 33 measures, 7 of them are about patient experience, and they come from a standardized measure known as CAHPS. 6 of them are about care coordination and patient safety. 8 relate to preventive health measures, and the others relate to certain at-risk groups. Those that have diabetes, there are 6 measures for those, 1 related to hypertension, 2 related to ischemic vascular disease, 1 related to heart failure patients, and 2 related to patients with coronary artery disease. So I've given you a lot of detail about the Medicare Shared Savings Program, but there's a different track as well known as Pioneer ACOs. And these are for ACOs that are a little bit further along in their development and are willing to take on more risk in order to take on potentially greater financial benefits. In this case, unlike the Medical Shared Savings Program, you have to have a minimum of 15,000 beneficiaries in your program. If you demonstrate significant savings in the first 2 years, then you are eligible to transition from a fee-for-service type payment from Medicare to a capitation payment. Also, those in a Pioneer ACO model must negotiate similar arrangements with other payers after the second year. So, unlike the Medicare Shared Savings Program, a Pioneer ACO has to become multi-payer. That is, include Medicare and at least one other payer with a similar kind of arrangement to what is going on with the Medicare program beginning after the second year. So after all this description about Medicare ACOs, an important question can arise as to whether the Medicare fee-for-service program will ultimately disappear. I think it's probably safe to say that this won't happen immediately, and it's probably never going to happen entirely. I think we are likely to see incentive payments over time that will encourage physicians to join integrated care delivery systems like ACOs. So, for example, one might imagine that some of the policies that might resolve some of the disagreements between physicians and the Medicare program related to the sustainable growth rate, SGR, and payment rates in the fee-for-service system of Medicare might in fact have different mechanisms built into it to encourage higher payments to physicians if they join integrated care delivery systems like ACOs. That policy is not currently in place, but one could imagine those sorts of carrots to encourage physicians to join integrated delivery systems like ACOs over time. Now, how will all this tie into the payment that radiologists can anticipate? Well, first of all, it should be said that any savings that are incurred in an ACO, how those dollars are redistributed back to physicians and providers in the ACO is determined by the ACO. An ACO requires, Medicare ACO requires that there be a plan in place ahead of time for how the savings will be shared, but how that is done to different kinds of physicians in the group is up to the ACO to determine. Under an ACO model, one could start to anticipate that radiology becomes more of a cost center than a revenue generator. And so that this raises an important issue about a need for a business model, perhaps for consultations that don't result in as many tests being ordered, particularly with those that are not appropriate or less necessary. And so that there's going to be an increasing need for research on appropriate use of imaging studies and their impact on outcomes so that ACOs may make the most cost-efficient use of these services. This is also recognized in the Affordable Care Act, which developed a new entity called CMMI, the Center for Medicare and Medicaid Innovation. And it has, in the Affordable Care Act, it specifically mentioned that CMMI should study the use of varying payment to physicians who order advanced medical imaging according to adherence and appropriateness criteria. CMMI, which has a budget of approximately $10 billion over the next 10 years, has an opportunity to do demonstrations of new payment models for the delivery of care. And they've already funded 2 projects in the area that are relevant to radiology. One is to a program in Chicago, which is using decision support and radiological immediate consultation on the front end of test ordering. This program is a $5.9 million project that is studying the effectiveness of this strategy to lead to a more appropriate use of radiologic tests and to see if it's cost effective to use these decision support and a radiologic consultation up front prior to performing tests. There's also a project in Detroit that is creating a data exchange between primary care physicians and radiologists, again to promote evidence-based use of radiologic tests before they're actually executed. There's much underway and much changing because of the Affordable Care Act. If you want to follow some of these changes going forward, here are some important websites that will allow you to see some of those changes. One is the Center for Medicare and Medicaid Innovation, and the other 3 are foundations that are actively involved in trying to provide information to consumers and providers about how the Affordable Care Act may change practice in the years ahead. So in the near future, providers can anticipate a confluence of forces. As this meeting is highlighting, there is an increasing public and professional awareness about radiation safety that will challenge clinicians to become more involved in determining the appropriate use of imaging studies in clinical care. And as I've tried to highlight in this talk, payers, most particularly Medicare under the Affordable Care Act, is looking to evolve from a fee-for-service system that currently rewards volume to a payment system that will reward value, and Medicare will be receptive to reimbursing radiologists based on their ability to increase the safe and appropriate use of imaging studies through pay-for-performance, accountable care organizations, and other innovative payment models. Thank you very much.